Welcome to the Acupuncture Outsider podcast. My name is Richard Hazel, and in the time it takes for you to commute to or from work, I hope to have shared something of interest about orthopedic acupuncture using motor points, trigger points, myofascial slings, neurofunctional acupuncture, segmental treatments, anything that crosses my mind that seems to be of interest. I hope you'll enjoy it. Hello, and welcome to another episode of the Acupuncture Outsider. This is Richard Hazel, and today I'm going to tell you about a couple cases, a follow-up on the ACNES case and a new patient that I saw with a different nerve entrapment. So the ACNES case, if you heard my episode, it's a woman who had one-sided burning pain and that went around the abdomen and seemed to start in the low back around the QL area. That's how it felt to her, that it would start there, but then it would be burning pain that went down into the groin, wrapped around the left abdomen between the ribs and the pelvis, and then would go down into the groin. And I thought that it was an ilioinguinal iliohypogastric nerve entrapment. It also caused nausea and a deep ache in her stomach and loss of appetite. So I think I mentioned it already, but she had all the GI tests and everything. But anyway, so I was treating it like it was ilioinguinal iliohypogastric, and I wasn't getting very far. And then I was looking at Dr. Andrea Trescott's peripheral nerve entrapment book about ACNES, which is an abdominal cutaneous nerve entrapment syndrome. And it had some similar symptoms. I was able to, and the interesting thing is for an ilioinguinal nerve entrapment, you're palpating the border of the rectus abdominis, especially low below the umbilicus. So, and that was positive. So that's why I really thought it was that. But then what it turned out was that higher up along the rectus abdominis, all the way up toward the sternum, like there, maybe the one right below the level of the sternum, was also very painful. And so I found three rectus abdominals that were very sensitive on palpation at the border. So I switched up my possible diagnosis to ACNES, and I only treated the rectus abdominis motor points at those levels that were sensitive, including the lower one below the umbilical area. But then there were a few up, or two more above the umbilicus, closer to the xiphoid process of the what am I saying? Like near the sternum. So I treated it, and she felt after the first treatment, her nausea went away, but she still had the nerve burning occasionally, and usually while standing. So I treated it again, and then I just saw her this week. She said, well, I have to tell you that for 2 days after the treatment, I had a lot of muscle pain there. It felt really, really sore. And then the pain went away. And I said, so what are your symptoms? She said, well, I don't have any more nausea, and I don't have the burning. I just have like a deep ache in that area. So she was about 3 or 4 centimeters below the lower rib. On that side. And she still had some pain in the groin area, especially below the inguinal ligament. So I hypothesized that the pain she had left was purely muscular and coming from the psoas. And I had released her psoas way early on, when she was in a lot more pain with a couple different nerve patterns, like a lateral femoral cutaneous burning down the leg. She had the ilioinguinal. She had low back pain. She had even sort of almost like a superior cluneal burning around the iliac crest. So she was like full of what looked to me like lots of cutaneous nerve entrapments. And so I then a lot of that cleared up after one or two sessions, but this is what was left. So I'm down to thinking it was that what's left is the psoas. So which would explain why the QL kept getting tight. But and she has a history of all sorts of other issues. She's had so many surgeries in her life. And so she had, a scar in her abdomen. She had lots of reasons that you could find these possible nerve entrapments. So, so I released her psoas again yesterday, and I really think that's going to be the resolution. I've done it before, but I think it needed another treatment. Released it below the inguinal ligament at the motor point, and she felt really good after, at the end of the session. I'm hopeful that that's what the deep ache in her abdomen was coming from. I think it was the psoas. So we're going to see, because I think she was feeling it in both locations, same problem. That would also, in my mind, explain how the rectus abdominis got so tight that it would entrap the nerve. If she had a long-term psoas issue that was weak and tight, her rectus abdominals would, I would argue, work a lot harder on any kind of flexion, any kind of lumbar flexion, any kind of stabilization with the core. If her psoas was weak on one side, maybe her rectus abdominals were working harder on that side for core stabilization and intra-abdominal pressure. So I'm pretty sure she's going to be way better, which I'm excited about, because this was a case where she cried every single session because of her feeling of hopelessness, that nobody could figure out what was going on. And even though I was giving her relief, I was still not completely fixing the problem. So she still was feeling really distressed. I think she has a lot of trauma from having survived cancer and had a lot of other surgeries. She just, every time she turns around, they're finding something that they need to surgically remove. So she has a history that leads to, I think, a lot of anxiety about one's own health that is understandable. So, so I'm feeling really hopeful that I may have gotten her out of the woods on this thing. I'm hopeful. A patient of mine in his, I would say, mid 70s or so, reached out to me to ask if I treat sciatica, which kind of made me laugh, because I treat sciatica like, if not every day, almost every day, I'm treating somebody with sciatica, and I get great results with sciatica. So I'm like always ready to handle somebody else with sciatica. Bring them on. My approach seems to be very successful in very few sessions. So his daughter has sciatica and needed to get in. I had like one availability the next day where someone had canceled. And so she was able to schedule for the next day. And so she comes in, and she was in a lot of pain. And I think they put her on something like Celebrex. They put her on some sort of nerve medication. And so I thought, typical sciatica, let's check the deep rotators. Let's see if she has any sensitivity at like L5S1, spinous processes. Let's palpate all the muscles that tend to get irritated. My normal approach, look for tight psoas, anterior pelvic tilt, etc., right? So she's telling me excruciating pain when sitting, especially on the toilet or a hard seat. And I'm thinking, okay, yeah, that's probably mostly like the deep rotators, the gemelli, the obturator internus. That's pretty normal. Sciatica gets worse when you sit on a hard chair or you sit low, like at the toilet. And then I said, so are you getting anything in the leg? She's like, yeah, in the back. I'm like, oh, in the hamstrings, in the back of your leg, yeah. Um, and what about the low leg, like outer low leg? No, not really, nothing there. And she says she gets this like burning and shooting pain. So I said, okay, well, let's do some assessment. Um, I wanted to palpate spinous processes. I wanted to check her deep rotators, see if she has limitation on hip internal rotation. That's always a dead giveaway that the deep rotators are irritating the sciatic nerve. So upon exam, sorry, upon exam, I wasn't finding all the usual suspects. I'm like pushing on the glute medius, no sensitivity. Piriformis, not too much. The deep rotators, no, not really. I said, okay, so where is the pain exactly? Where do you feel it when you feel it? So she puts her finger on the inner border of her ischial tuberosity. And that's when she tells me that the pain is actually going underneath into the inner thigh and to the side of her rectum and vulva. Shooting pain. She says, I have not cried so much in the past 5 years as I have this past week because of how much horrifying pain this is causing. She said, if I didn't have this Celebrex, I don't think I could have made it to the appointment, to tell you the truth. So, so I'm telling her, okay, so number one, this is not sciatica. Okay, this is not. And I showed her the pathway of sciatic nerve. This is where you would have symptoms for sciatica. I don't know who called it sciatica, but this is not sciatica. Okay, um, it looks to me like an inferior cluneal nerve entrapment. So I'm palpating. I said, so where in the hamstring do you get pain? She doesn't know the names, but she points to her hypertonic semitendinosus. So upon palpation of the semitendinosus, I'm like, are you flexing your hamstring right now because you're nervous? She's like, no, it's been that tight. It's been killing me. So her semitendinosus is like a rock, and I'm palpating, and definitely that's part of the problem. Um, and then I'm thinking, what about near the piriformis? Is there an entrapment of the inferior cluneal nerve near the piriformis? So when I'm palpating the piriformis near where it attaches to the sacrum, she had pain right above the piriformis and a little bit below it. So, and then she didn't seem to have pain when I palpated the lower glute max area, but I decided to try to neuromodulate the inferior cluneal nerve, which innervates there. I am going to put needles in the lower glute max. So I put needles in the lower glute max. I put needles in her hamstrings, both of them, and I put needles into glute medius and piriformis. And I used just electric stimulation, 10 minutes, 1 hertz, loosen everything up, see how it feels. She sits up, same burning, still has burning. I said, okay, I'm gonna do some dry needling. You're gonna be sore, but I need to work on like some really taut bands that I felt to help you. She said, you do whatever you need to do. I'm not afraid of the needles, and I can't live like this. So just do what you got to do. So with her permission, I dry needled a lot of the piriformis where there was a lot of soreness. It's interesting. She had soreness in the same area where you would feel for a superior gluteal nerve entrapment right above the piriformis near that iliac notch above. So I did put a needle in there and use some electric stim in case there was some entrapment there. But dry needling, piriformis, dry needling, the upper hamstring semitendinosis where it attaches to the ischial tuberosity, and I felt like I got good release of both of those areas. And when she got up, she said, "It's definitely different. It's definitely not as intense." I said, "What if you sit on that chair for a minute and see?" Because the chair I have in the treatment room is low enough that it might have created some of the nerve pain. And she sat and she said, "Yeah, it's different. It's definitely different." She said, "I still feel something," and she was pointing to the upper hamstring. And I said, "Okay, that may just be soreness from the needles." She said, "Yeah, it feels like sore." I said, "It's not burning, it's not shooting, right?" "No, it's not." And I said, "Okay, I have a follow-up appointment available that I can do on Friday." That was like Wednesday. I said, "I can see you on Friday if it's not feeling better, because I know this is a horrifying experience. I don't want you to wait till next week. If you can get in, I can get you in." And she said, "Okay, I'll let you know tomorrow." I said, "Yeah, that's fine." Um, and she would have to take off work to come and see me. So that, I think that was like in her head too. She didn't want to miss more work. So I did not hear from her on Thursday. And then Friday, she booked an appointment for next week. And the note on the appointment was, "I'm feeling much better, but I want to come in to see if it'll get even better." So I'm guessing she's having a lot less nerve pain and probably having some muscular pain, maybe SI joint or the ischial tuberosity. We will see. But I'm really happy that it worked, that the treatment helped. Um, I think typically this sort of inferior cluneal nerve entrapment would be treated with lidocaine injection or cryo nerve sorry, cryo nerve ablation, or cryoablation, um, but dry needling for the win, I think, in this case. So I'm happy. I'm happy for her because that sounded horrible. And it's the first time that I've actually encountered the inferior cluneal nerve entrapment. I've seen the superior cluneal nerve entrapment so many times, but this is the first time that I've encountered this inferior cluneal nerve entrapment. And according to Dr. Trescott, it's often not diagnosed. People suffer. The assumption is there's some sort of pudendal nerve entrapment or pudendal nerve irritation, um, and they just don't get the treatment for the actual problem. Now, is it possible that it was more pudendal than inferior cluneal? Possibly, but I think the fact that the pain was lateral to her rectum and not actually in the rectum, I think means it's the inferior cluneal nerve. And based on where she was pushing, it looked just like a photograph of Dr. Trescott palpating for that entrapment. Is like the medial border of the ischial tuberosity, or the ischium, as she would say. So I think that was what it was, and yeah, I think dry needling was the solution in this case. Now I'm going to see what her symptoms are. Obviously, if there's more to this story, you will hear about it. But I'm really happy about the result. I'm really happy that I recognized it for her sake, because if I didn't see her, if her father hadn't sent her to me, she probably didn't know I exist. Where would she be today right now? She would be suffering, like seriously, and probably eventually not making it to work. or who knows how long it takes to see a specialist. Lately, most of my patients are waiting more than a month to see a specialist. Um, all the horror stories they used to tell us about Canadian socialized medicine and how people had to wait for doctors. Well, we're living it too, but we don't have socialized medicine. So, I say, bring us affordable health care. If we're already going to wait for a specialist, then give us something we can afford. And that doesn't make people go into bankruptcy because they got a serious medical diagnosis. So anyway, interesting case. I will definitely update you on both of those cases if anything new happens, especially if the abdominal cutaneous nerve entrapment is resolved and she's finally going back to her normal life. She has a neurosurgeon appointment next week that she made over a month ago, and basically has been seeing me in hopes that she won't need to talk to the PA for the neurosurgeon, but she is going to the appointment. She has other things that need to be looked at, and probably surgery will be involved. It's not disc related, and I'm not going to talk about what's going on, but she has other concerns. So anyway, I'm happy that both of them are getting better. And, this is probably like the 40th episode where I've mentioned Dr. Trescott's book. So you might want to think about getting it if you don't have it. The Peripheral Nerve Entrapment book is from Springer as the publisher. And you can get a pretty good price for it on Amazon. And there is a Kindle version, even though it's hundreds of pages. So I have both. I have the print version to show patients, and I have the Kindle version to, look things up and read more thoroughly no matter where I'm going. I can sit and eat my lunch and read about cluneal nerve entrapments. So, so think about getting that book if you are specialized in treating pain, because you're going to get the tough cases that nobody else could fix. Nobody goes to acupuncture as their first line. And I'm not suggesting that they should. I want people to see their medical doctor anytime they have a problem. But after they see their medical doctor, I want them to come and see me. Once we've ruled out anything that needs surgery, come and see me. Then think about the surgical procedures, etc. If acupuncture isn't working, because 80-90% of the time there is an acupuncture solution that will help avoid major intervention. Okay, that's it for today. Have a great week. Take care.